Obsessive compulsive disorder, or OCD. What is OCD? OCD is an anxiety disorder where people experience unwanted repetitive thoughts or images or urges that causes significant distress, leading to repetitive behaviors or mental acts to relieve anxiety. Obsessions, recurring intrusive and unwanted thoughts or images or urges that causes significant anxiety. Compulsions, a repetitive, intentional behavior or mental act performed to neutralize anxiety or distress caused by an obsession or to prevent a dreaded end. Symptoms and features of OCD. Symptoms of OCD. You have cognitive symptoms, emotional symptoms, and behavioral symptoms. Cognitive symptoms. Self-doubt and need for perfection. Self-doubt. Salofsky and Forster 2000 found that self-doubt leads to repetitive actions, leading to explaining your actions. Need for perfection. Having a rigid definition of success that they are constantly striving for. Emotional symptoms. Ruminations. Thinking for too long, unproductively. Dwelling on things, going over intrusive thoughts. Anxiety. A feeling of unease and worry, usually characterized by a peak of adrenaline and increased heart rate. Behavioural symptoms. Contamination. Fear that things are contaminated and may cause an illness to an individual or family member. Hoarding. You find it impossible to throw things away, feel as if they need the object due to emotional attachment or because it prevents harm. Features of OCD. 1.2% of the UK population suffer with OCD. The two most common types of OCD is germs and hoarding. 76 to 80% of individuals with OCD also have anxiety. 13.5% to 27% of people with OCD attempt suicide. There's a high percentage of OCD in China and Saudi Arabia. Biological explanation of OCD. Neuroanatomical explanation. OCD and the brain. The neuroanatomical explanation of OCD explains that there's an abnormality in the central nervous system in people who have OCD. Sufferers have a faulty neural circuit that links the orbitofrontal cortex to the thalamus. An OCD brain is overactive and doesn't have an ending. Parts of the brain associated with OCD. The caudate nucleus inhibits the action of neurons that depend on the activity in the thalamus. It's a brake for the thalamic activity. The orbitofrontal cortex, or OFC, which I will now refer to it as, alerts the brain to the potential worries in the environment, decoding and representing some primary reinforcements, for example, taste and touch. The putamen is crucial for regulating movement and learning and reward processing. It's a very complex feedback loop and it prepares and aids in movement. Globus pallidus fibres act as a braking mechanism. They control activity in the thalamus to do with planning and execution of movement. The caudate nucleus tail has a role in both motor control, learning, reward processing, and decision making. The thalamus controls alertness, conscientiousness, and how we act and respond to things. Cingulate cortex is crucial for linking emotional responses to behavior. It plays a role in decision making, detecting errors, reward and punishment, and how we adjust afterwards. Differences in a brain of a person with OCD compared to a normal person. Now, as stated before, an OCD brain is seen as overactive. A caudate nucleus in the brain of a normal person inhibits the action of globus pallidus fibres. However, in a person with OCD, it tends to be overactive. Therefore, it does not inhibit the actions of globus pallidus fibres. In an OCD brain, the caudate nucleus is overactive, leading to an overactive hypothalamus, which creates a reaction in the OCF, therefore leading to an increased stimulation and causing a loop of hyperactivity or repetitive thoughts. In the brain of someone with OCD, they have an overactive OCF. This leads to alertness, anxiety, and checking behaviors. Globus pallidus fibres allow us to forget the way it was before. However, due to the caudate nucleus not inhibiting the actions of the globus fibres, we now remember the positive reinforcement that the compulsions give us and forget what it's like to live without the compulsions. The caudate nucleus tail has a termination which stops intrusive thoughts. However, there's an issue in the angle and it doesn't finish the termination. In a person with OCD, this leads to obsessions. The thalamus. In a normal brain, it contains primitive checking and cleaning behaviors. However, It's overactive in an OCD brain, so it triggers compulsions leading to engaging in behaviors associated with cleaning behaviors and primitive checking. Strengths. Feng 2007 bred mice with a specific gene missing which is expressed in parts of an OCD brain. This led to the mice displaying excessive grooming and anxious behavior. However, this study is low in generalizability due to using animals, and you cannot compare their behavior to humans. However, mice share 70% of DNA and the same amount of brain structure and brain matter as humans. The use of antidepressants to raise serotonin levels have been successful in treatments of OCD. Therefore, if biology can remove symptoms, it can be deduced that biology caused the symptoms. OCD can therefore be seen as caused by biology due to it being treated by serotonin. Somorow et al. 2007 found that antidepressants were more effective for sufferers than a placebo. As OCD runs in families, it could be due to genes that the brain function differently. Therefore, this is proof that the biological explanation is reliable due to it being inheritable. It's deterministic. It reduces the blame from the individual. This can lead to a sense of relief as well as early intervention. Now we have MRIs and PET scans. We can see into a person's brain with OCD and understand that a person's brain with OCD is overactive. We can see how they have an overactive thalamus, and we can see the activity of a person's brain with OCD whilst they're doing tasks. Therefore, this theory has scientific status. Weaknesses. Krev et al. 2012 found that other areas of the brain took over the functions of the anterior cingulate cortex. It takes up to 12 weeks for antidepressants to work when they raise serotonin levels immediately, suggesting that it's not just a biological cause of OCD. If so, behavior should have improved immediately, due to serotonin levels being raised immediately. This approach only considers the nature argument. It believes that the cause of OCD is the brain structure, not considering how it may be learnt through family members. However, it's been proven SLT is not the likely cause of OCD by children sufferers having different symptoms to their parents. Therefore, the nurture argument could not be relevant. Determinism. The fact that behavior is caused through something innate, which could remove free will. If you have this brain structure, then you're going to have OCD. This can lead to individuals acting a certain way, and it removes the blame from the individuals from the way that they act, and it can also lead to them acting how they're meant to. The cognitive explanation of OCD says that it's caused by self-doubt, the need for perfection, and feelings of responsibility. Therefore, there's more than one reason for actions like this. The non-biological explanation of OCD, the cognitive theory. Faulty information processing is when biased attention is paid on a threat or irrelevant information, and it's difficult to inhibit responses. Perceptions or thoughts we have about our experiences will trigger an emotional response, which will lead to us triggering a behavior to deal with this response. A lack of confidence. It's been said that people with OCD have a lack of confidence in their memory, and this can explain checking behaviors. They do not trust in their recall and feel compelled to check. Inflated responsibility. This is a cognitive bias where you believe you are personally responsible for causing harm or failing to prevent harm. Woods et al. 2000 did a meta-analysis of studies that aimed to test how memory related to checking behaviors and found that those suffering with OCD had a slightly worse memory for recall, and they felt as if their memory was inadequate compared to controls. Combined, you can see how faulty processing information and lack of confidence may lead to symptoms of OCD. Hypervigilance is being constantly in fight or flight mode. It's a physical illness, and it can lead to difficulty sleeping, eating too much, or not eating enough. Detection of threats then triggers high anxiety, which leads to compulsive behavior, which reduces anxiety. People with OCD may be hypervigilant. This is supported by Williams et al. In 1997, meaning they are constantly scanning for threats in the environment and have an attention bias towards potential threats, forming the basis for obsession. Ranhan, 2004, a case study of someone with OCD centered on blood, could recall all their past experiences with blood. This shows hypervigilance. Early childhood experiences. Traumatic events lead to those with OCD to find their obsessions and latch onto these events. Overprotective parents and controlling parents interfere learning attitudes which lead to the development of OCD. Early childhood experiences could cause a general negative belief system about how the world works. This could lead to intrusive thoughts which are misinterpreted and made important, causing anxiety. To deal with the anxiety, a person adopts a counterproductive behavior. This gives them temporary relief, reinforcing the faulty thought pattern. Unless broken, it becomes self-perpetuating. Strengths. Pediatric OCD treatment study, POTS. This is a study that you will have learned about. POTS found that CBT is a better treatment for OCD than drug therapy. Slofsky and Kirk, 1997. They studied people with OCD, and they told them to keep a diary. Diaries of people with OCD who were told deliberately to suppress their thoughts, but others were allowed to reign free. The frequency of intrusive thoughts were higher on days that they tried to suppress them. However, this study was self-report data, so therefore it cannot be truly reliable. Van Volkum et al. 1966 found that CBT it was just as effective as drug treatment. This theory has practical application of CBT, therefore it has high face validity. Weaknesses. This theory puts the blame on the individual and parents, so therefore it lacks determinism. There's no argument to say people should be hypervigilant towards threats, so therefore this doesn't explain why people with OCD do have these compulsions. It doesn't consider the role of individual differences in why some young people overcome childhood experiences and don't develop OCD. There's no evidence that faulty cognition actually leads to symptoms. The other explanation of the brain. Treatments for OCD, drugs, specifically antidepressant and anti-anxiety drugs. Anti-anxiety, clozapine, it was originally used to treat tuberculosis, however, now is a sedative for OCD sufferers. It can lead to new patterns of learning due to the control and lack of stimulation it allows. However, as said before in the schizophrenia video, drugs like this that allows for sedation can be seen as a form of social control due to it being seen as a chemical straitjacket. Benzodiazepines, for example, Valium and Librium, these increase the activity of GABA, quieting many neurons in the brain. GABA reacts with GABA receptors on the postsynaptic neuron, inhibiting neurons to be stimulated by other neurons. This enables the individual to feel more relaxed. Antidepressants, SSR, fluoxetine, Prozac, Proexene, Parallax, and Zoloft, Sertraline. SSRIs treat both the primary symptoms of OCD as well as the secondary comorbidity depression. This reduces the reuptake of serotonin into the presynaptic neuron, increasing the amount of serotonin in the synapse. It blocks the transporters, increasing the stimulation of the postsynaptic neuron. Tricyclics, TCAs, they work as the same way in serotonin, but also increase the amount of noradrenaline in the synapse. Noradrenaline is associated with emotion, particularly mood control. Noradrenaline is involved in the function of sleep and dreaming, as well as learning. So if you don't know what desert is a useful way to evaluate treatments. It stands for direct, effective, side effects, slow/fast, ethical, relapse rates, and types of people. Direct. Psychiatrist decides the type of medication, for example SSRIs, the dosage and any changes. The patient has little control and mainly follows the medical instructions. Therefore, this is a direct type of treatment. Effective. Sumo et al. 2007 compared SSRIs and antidepressants with a placebo drug. The drugs are more effective than a placebo, reducing the amount of symptoms. This shows that it's reliable and effective. Side effects. Nausea, headache, anxiety, leading to self-harm and increased risk of suicide. Monitoring the patients whilst on antidepressants and anti-anxiety drugs is required. Slow. This treatment is a slow type of treatment. Corian et al. 2000 found that antidepressant medication had a long-term effect compared to placebo and was better at preventing relapse over an 80-week trial. SSRIs take up to 12 weeks to work. Ethical. There's a publication bias where results of drug trials are more likely to be published if they have positive results. Goldcare 2013 found that drug companies were selectively publishing positive outcomes for drugs their sponsors were selling, which is deceiving. Relapse rates. Stopping the drugs later carries on a high risk of relapse. Corian et al. 2000 and Roman et al. 2001 showed that 17.5% and 21% of relapse rates, respectively, when a drug was continued, and 38% and 59% respectively in a placebo group trial. Types of people. Comorbidity disorders are much more likely to be offered drugs due to it being easier for them to do than CBT due to needing motivation for CBT. Treatments of OCD, CBT, exposure and response. What is CBT? CBT is based on cognitive as well as learning theories. It addresses thinking and behavior involved in OCD. Obsessions are negatively reinforced by avoidance. Compulsion rituals are associated with anxiety. The client usually engaged in 30 to 20 sessions with monthly follow-ups. It can be done through group therapy, self-help books, online, family therapy, or structured activities. Patient-therapist relationships are important, and focusing on the therapist being non-threatening and supportive. CBT involves examining the things you do, think, focusing on goals and the present day, and how your thought affects your feelings and behavior. Response prevention (RP). This is based off classical conditioning. The client is taught that the obsession that previously created anxiety is no longer produced this response. They are prevented from engaging in compulsive responses. List/rules are often given, i.e., only vacuuming for half an hour a day. New routines are provided to restrict the compulsive behavior. Exposure. An individual is presented with fear until anxiety reduces. The fear is presented in a hierarchy from least to most threatening. Relaxation techniques are taught to use outside of therapy. So if you don't know what desert is a useful way to evaluate treatments. It stands for direct, effective, side effects, slow/fast, ethical, relapse rates, and types of people. Direct. The therapist leads the process, setting structured tasks such as exposure and response prevention. They challenge the patient's thoughts and behaviors, guiding them step by step whilst the patient actively follows instructions. This directly challenges their behavior. Effective. ERPT would not be effective for those without compulsions. However, therapy has been promoted as the first choice by NICE, and it's effective in reducing symptoms and can be applied flexibly. Improvement in 50% of cases, but the effectiveness is increased by combining with drugs. And POTS 2004 found that CBT is more effective compared to drugs. However, it was proposed that this was due to the therapist. Slow. Now this is a slow treatment. It takes 30 to 20 sessions with follow-up. Some people cannot cope with the effort and distress involved. Success depends on the client. It may be beyond the client's power. CBT may be unable to help people without the use of drugs alongside it. Ethical. It's high in ethics as it allows the person to take control of their own treatment. However, it could lead to discomfort due to having to face and be exposed to their anxieties and constantly try to resist their obsessions. Relapse rate. 50 to 60% of people who complete ERP treatment shows clinically significant improvement in OCD symptoms, and treatments shows to have maintained a long-term effect. Types of people. It's not effective to type of people who do not have compulsions, which equates to about 44% of people with OCD. It only works for individuals who are motivated to change. It requires a lot of personal input, time, and attention.